This is our pain research update for April 2025. We don't have that many articles this time, so let's get into it. The first is a systematic review meta-analysis of 55 RCTs looking at the value of physical therapy after lumbar surgery. So 55 studies, and they go on to show that any exercise program that address spinal column strength, flexibility, endurance, those are all good things. They also found that manipulation of the tissues, manual medicine, acupuncture, education, all these different things can help in the long run. Is that really common sense? Not really. If you think about it, there's two categories of people who end up with a lumbar surgery. One is people who had a trauma, high velocity injury, damage to the spinal column, disc bulge, surgery. The other kind is the exact opposite, the sedentary who don't do anything much and for long periods of time, where their body or their spinal column is against gravity but not in a correct position. And these kind of people, what ends up happening is there's wear and tear that leads to eventually an IVDP, and then from there they may or may not qualify for surgery. So the question then becomes, is their initial condition deficiency of surgery? The surgeon will take care of the disc bulge. Well, that's perfectly accurate, that's correct. It's going to be, when it follows a proper criterion indication, it's the correct thing to do. But the question no one asks is, why is the disc bulging? Why is that thing sticking out in the first place? And that's where things become tricky, because it's not deficiency of physical therapy. It's no longer deficiency of manipulation, acupuncture, education, whatever else. It's really just a problem with the way the person uses their body. Showing a person how to use their body and use it the way it's designed to be used is challenging. But this is the bottom line here. Are they wrong in saying physical therapy after surgery is the greatest thing? Not really. But their problem is not deficiency of physical therapy. We have another study here that looks at the correlation between sleep and depression and compliance with exercise. Now this is kind of interesting. It's also kind of common sense. But they tracked elderly people to see who was doing exercise, who wasn't, and what their sleep quality and depressive symptoms were like. And as expected, those who did not sleep well and had depressive symptoms did not feel like exercising, so their compliance was low. What do we do about that? Now that's the tricky thing. As people get older, they do need more sleep, but too much sleep or too little sleep is a problem. The other thing is depressive symptoms. We have to find out why those things are there. The bottom line is, as clinicians, we can always tell a person, go do more exercise. But if we don't find out why they're not complying, our words are empty, they don't mean anything. And it really means just getting a better history. You get a better history, you can see what's actually going on. Where do you start? You start by seeing how their mood is, how is their sleep. These are good places to look into when you find people who are not complying with prescribed exercise programs. The last is a systematic review looking at the connection between migraines and proton pump inhibitors, hyperacidity medications. Now, what it finds overall is that there's no connection between the two things. Now, it's been hypothesized multiple times. They have 1.5 million people, and migraine sufferers in general tend to be female. This sample had more men, and not only that, the men actually had a significant association. So while they say there's no actual association, the men did have a significant association anyway. What does that really tell us? This is tricky. There's no straight answer to it, but PPIs, these antacid drugs, will change the bacterial flora. Changing the bacterial flora can determine how we handle stresses in life and whether those manifest as a migraine later or not.